There is a reason your body responds the way it does after you walk out of a doctor's appointment, where surgery was mentioned. That odd mix of relief that someone has a plan and something quieter underneath it. Something that never quite settles. You nodded in the office. You said you understood, but that night at your kitchen table, holding whatever paperwork they handed you, you were not entirely sure you did. What I am about to share is not about scaring you away from medical care. It is about the specific questions that protect you inside it. And before this video ends, I am going to give you the one question that research shows most patients over 60 never think to ask before signing anything. If you are watching The Healthy Habit for the first time, subscribe right now and turn on notifications. Every week, I share the kind of honest, practical health information that used to require having a doctor in the family. Hit that subscribe button and let's continue. I'm Dr. Gerald Mark, and what I have observed consistently in clinical practice is that surgical risk after age 65 is not a footnote at the bottom of a consent form. It is the entire conversation, and most patients never know to ask for it. By the end of this video, you will know the 5 specific surgeries where age changes the math the most, and the one question that applies to every single one of them. The body at 65 is not the same body it was at 45. The heart that has been beating for 65 years responds to anesthesia differently. It takes longer to stabilize, longer to clear medication, and that difference is quiet, and it is exactly where complications begin. The brain, particularly in adults over 70, is genuinely vulnerable to a post-surgical syndrome that most patients have never heard of, and most families are never warned about. Research published consistently across peer-reviewed journals shows that adults over 65 face significantly elevated rates of major post-surgical complications compared to younger adults undergoing identical procedures. Not because of poor surgical care, but because of normal physiological changes that interact with the stress of surgery in ways that are difficult to predict. There is a patient I want to tell you about, a woman named Marguerite, 74 years old, active, independent, and sharp as anyone I have known. Her story is going to stay with us through this entire conversation, because what happened to her after surgery is something every person watching this deserves to understand before they ever sign a consent form. Think of your body's ability to handle surgical stress like a savings account. When you are younger, that account has a deep reserve. Surgery makes a significant withdrawal, the anesthesia, the physical trauma, the full demands of recovery, and the body has enough in reserve to absorb it and rebuild. After decades of living, that reserve has naturally decreased. Not emptied, decreased. And when surgery makes the same large withdrawal from a smaller reserve, the body sometimes cannot cover the cost. Recovery stalls. Complications develop in places that seem unrelated to where the surgery happened. The downstream effects on the brain, the heart, and the kidneys can be more serious and longer lasting than anyone in that pre-surgical consultation room described. That quiet gap between what surgery costs and what the aging body has available, that is the gap most patients fall into without ever knowing it existed. Marguerite was a retired school teacher, still gardening every morning before the heat came up, still driving herself to her grandchildren's school plays, still cooking Sunday dinner for her whole family every week. She had real back pain, the kind that slowed her down, but she was managing it, and by her own account she was doing reasonably well. Then the pain intensified. Her orthopedic surgeon recommended spinal fusion surgery. He was a good surgeon. He explained the procedure clearly. Marguerite asked if it would help, and he told her honestly that in most patients it did. She signed the forms. What nobody walked Marguerite through was how her age, her slightly elevated blood pressure, her mild kidney insufficiency, and the length of time under general anesthesia would interact with each other. The fusion was technically clean, but Marguerite spent the next 4 days in a state her family had never seen, confused, agitated through the nights, not recognizing her daughter's face at certain moments. The clinical team called it post-operative delirium. It resolved, mostly. But 6 months later, her family said she was not quite the same. The sharpness, a little dimmer. The confidence, a little quieter. The surgery was not wrong. The surgeon was not negligent. Marguerite simply never had the full picture, and she never knew she was permitted to ask for it. 5 surgeries. 5 conversations worth having before any consent form gets signed. The first is open heart bypass surgery in adults over 75. This surgery saves lives and for many patients remains the right choice, but adults over 75 face substantially elevated rates of stroke, cognitive decline, and kidney failure following bypass compared to younger patients. Tonight, write down 4 words. What is my STS score? The Society of Thoracic Surgeons risk score calculates your specific surgical mortality and complication risk based on your individual health profile. Every cardiac surgeon can provide it. Most patients never know to ask. Knowing your number before you decide is not second-guessing your surgeon. It is participating in your own care the way every informed patient deserves to. Marguerite never saw a number before she made any decision in that surgeon's office. She understands now exactly why that question matters. The second surgery involves a conversation almost no family has until they are forced to have it in a hospital hallway at 2 in the morning. Hip fracture surgery in patients with advanced dementia. For most older adults, hip fracture surgery is necessary and life-saving. But for patients with advanced dementia, the surgery itself, combined with post-surgical delirium and the disorientation of recovery, can accelerate cognitive and physical decline significantly. A study in the Journal of the American Geriatric Society found that palliative management focused on comfort and dignity rather than surgical repair was chosen by informed families and frequently preserved quality of life more effectively. This is not a crisis conversation. This is a kitchen table conversation to have now. Marguerite once told her physician that her sister had advanced dementia. If that surgical moment had ever arrived for her sister, she would have known exactly which question to ask, because she had already learned what it costs not to ask one. Drop a yes in the comments right now if you have ever walked out of a doctor's office and realized afterward that you did not ask everything you needed to ask. I read every comment on this channel personally, and what you share shapes exactly what I bring to you next. The third surprises almost everyone. Major cancer surgery with curative intent in adults over 80. For some cancers, in some patients, surgery at this age remains the right path. But research published in JAMA Surgery has documented that for certain slow-growing cancers, prostate cancer being one of the most studied, active surveillance produces survival outcomes statistically comparable to surgical intervention in older patients, while eliminating surgical risk entirely. The conversation to request is not simply, should I have surgery? It is, what does the research show about active surveillance for my specific cancer type at my specific age? That question opens a door many patients never know exists. Choosing to monitor carefully is not giving up. In certain situations, it is the most medically sound decision available. The fourth is elective spinal fusion, specifically multi-level fusion in patients over 70. Marguerite's surgery. A study published in the journal Spine found that complication rates in adults over 65 undergoing multi-level lumbar fusion were significantly higher than in younger populations, while functional improvement was frequently more modest than patients expected. Before agreeing to spinal surgery, request at minimum 12 weeks of structured physical therapy first and ask directly, if we monitor this for 6 more months, what is the realistic clinical risk of that delay? In many cases, the honest answer is considerably less alarming than the urgency of the moment suggests. The fifth is the one that stops most people completely. Elective open chest valve replacement versus transcatheter alternatives in adults over 75. For decades, open chest surgery was the only option for severe aortic stenosis. But research now robustly supports transcatheter aortic valve replacement, TAVR, as producing equivalent or better outcomes in appropriately selected high-risk older patients, with dramatically shorter recovery and significantly lower complication rates. Current cardiology guidelines have expanded TAVR eligibility considerably in recent years. If you or someone you love over 75 is being evaluated for valve surgery, asking whether TAVR has been considered, and why or why not, is a fully legitimate and medically important question. The question you did not know you were permitted to ask is very often the most consequential one in the room. Working with patients on exactly this issue, I put together something I call the Before You Sign framework. The clearest way I know to take everything we just covered and turn it into something you can actually use the next time you are sitting across from a specialist. 3 questions. Before any consent form. First, what is my specific surgical risk score for this procedure at my age and with my health history? Second, what happens if we wait or try a non-surgical approach first, and how long is that a reasonable option? Third, is there a minimally invasive alternative, and am I a candidate for it? Calm, respectful, and completely within your rights as a patient. Bypass surgery in adults over 75. Ask for your STS score before you decide. Hip fracture surgery in patients with advanced dementia. Have the palliative care conversation now, not in a hallway. Major cancer surgery in adults over 80. Ask specifically about active surveillance and what the research shows for your situation. Spinal fusion in adults over 70. Request a structured non-surgical trial before you schedule anything. And valve surgery in adults over 75. Ask whether TAVR has been considered and get a direct answer. The one question I promised you at the beginning, what happens if we wait, and how long is waiting a reasonable option? That question, asked calmly before any consent form is signed, has changed outcomes in ways no surgical technique alone ever could. Marguerite still gardens when the weather allows. She still drives herself to her grandchildren's recitals. The sharpness came back more than her family feared, but not entirely, and she knows it. She told her physician that the one thing she would do differently is slow down that conversation before she signed. She thought asking for more time meant she did not trust her doctor. She knows now that it would have meant she trusted herself. Most people will scroll past information like this without a second thought. You stayed. And what you are carrying out of this video, 3 questions, 1 framework, and the clear understanding that you are permitted to ask for all of it. That is a capability you did not have when you pressed play. Please share this video with one person in your life who has ever come home from a specialist appointment holding a recommendation they did not fully understand and felt too uncertain to question. That share may be one of the most protective things you do for someone you love this week. And before you go, one question for the comments. Of the 3 questions in the Before You Sign framework, which one do you wish you had known to ask before a medical decision you have already faced? Tell me below. I will read every response. Small habits, done consistently, are the most powerful medicine your body will ever receive. I'm Dr. Gerald Mark. Build one healthy habit today, and I'll see you in the next one. Everything I have shared today is for general informational purposes only, based on published research and clinical observation. It is not a personal diagnosis, and it is not a substitute for care from your own doctor. Please consult your physician or a qualified healthcare provider before making any changes to your medications, diet, supplements, or health routine.